My dear students, in this video, I'm going to discuss the salient points about the arrhythmias in the intensive care unit. Let us start with this case scenario. A 64-year-old male with diabetes and hypertension is admitted to the ICU with septic shock secondary to community-acquired pneumonia. During his stay in the ICU on day 2, the patient is still on noradrenaline at 0.18 mics per kg per minute and is ventilated mechanically with an FiO2 on a controlled mode with an FiO2 of zero point 0.5 and PEEP of 8 centimeter water. Urine output is adequate. And when suddenly the bedside monitor alarms. And on viewing, the vitals show a heart rate of 162 per minute, which is irregular, a blood pressure of 82 by 46, which was previously 105 by 65 millimeter of Hg. The MAP is around 58 millimeter of mercury. SpO2 is 93%, temperature is 38.9 degree centigrade. And this is the ECG, which a 12-lead ECG is done, and this is the 12-lead ECG, which shows irregular rhythm, no distinct P waves, along with narrow QRS complexes. So as it seems that this is the patient who has atrial fibrillation with rapid ventricular response, that is AF with RVR. Now, before we discuss on the specific management of this patient, let us discuss on why arrhythmias are common in the ICU. This is because there are frequently various pathophysiological triggers. They exist more than one in a patient, and different times they can change, like hypoxia, hypercapnia, and acidosis. Electrolyte disturbances, which can be due to hypokalemia, hypomagnesemia, or hypocalcemia, the presence of sepsis and systemic inflammation, myocardial ischemia or myocardial strain following pulmonary embolism or RV failure, catecholamine excess either endogenous because of stress or vasopressors, that is exogenous, drug toxicities because of QT prolongation, digoxin, antiarrhythmics, etc. Mechanical factors including the central lines, PA catheter, suctioning. So all of these are risk factors or triggers to arrhythmias. So therefore, in the ICU, when we see arrhythmias, we have to realize that there are often secondary phenomenon and which may reflect anything. It may reflect hypoxia, sepsis, electrolyte imbalance, myocardial injury, or drugs. And it always may not be due to a primary cardiac disease, which may be the cause in a normal, healthy patient. So what are the common ICU arrhythmias we see? The supraventricular arrhythmias are more frequent, and the most frequent in the ICU is atrial fibrillation. Atrial fibrillation followed by atrial flutter, which is often new onset during sepsis, post-surgery, and hypoxia. It causes rapid ventricular response, which worsens the cardiac output. It increases the thromboembolic risk with duration, and therefore one needs to be careful and attentive when the patient is experiencing atrial fibrillation, particularly a new onset one. Second is the paroxysmal SVT or the AV nodal reentrant tachycardias. So this is triggered by stress or catecholamines, and they're narrow, complex, and regular tachycardia. There can be ventricular arrhythmias which can be immediately life-threatening ventricular tachycardia because of structural heart disease, ischemia, electrolyte imbalance, and they can be monomorphic or polymorphic. The ventricular fibrillation, which can cause cardiac change in the cardiac arrest rhythm, and ultimately it will require defibrillation for its correction or treatment. And as I mentioned about the polymorphic VT or the polymorphic VT with prolonged QT can be there, which is Torsitis depointis. The common causes for which are hypokalemia, hypomagnesemia, and QT prolonging drugs. There can be bradyarrhythmias either in the form of sinus bradycardia, which may be due to hypoxia, hypothermia, or drugs such as beta blockers or opioids, or there can be high-grade AV block or complete heart block, particularly in inferior MI, myocarditis, electrolyte disorders, they often require temporary pacing in the ICU. And last but not the least, there can be pulseless electrical activity where there is organized rhythm without any pulse. And in those cases, we have to search for the reversible causes of the H's and the T's. So always when there is arrhythmia in the ICU, we have to remember and treat the cause first, whether it is sepsis, whether it is hypoxia, whether it is pain, whatever may be the cause, before escalating the antiarrhythmics. So, what should be the immediate ICU approach to any patient with arrhythmia? First step should be to assess stability. Stability in order to detect any hypotension, altered mental state, ischemic chest pain, acute heart failure, etc. If the patient is unstable, we have to consider synchronized cardioversion or defibrillation if the patient is pulseless. In the step 2, we have to identify and correct the reversible causes. The key pointers for the reversible causes will exist either in looking into the electrolytes, oxygenation, perfusion, or the drugs. Always try to keep a potassium target of 4 to 4.5, magnesium target of more than 2 milligram per deciliter, or which is equivalent to 0.8 millimoles per liter. Have to correct hypoxia, acidosis, etc. And always review the drugs which have a potential for prolonging the QT interval daily. If you have to manage specifically the patients, for example, the case that we had discussed in the beginning, in atrial fibrillation in the ICU, we have to go for rate control, in which the drug which is preferred is amiodarone, which is preferred in shock or in LV dysfunction. We can use esmolol, which is short acting and titrable, if the patient does not have any hypotension. Rhythm control, we have to consider if it is new onset and hemodynamically significant, that is causing hemodynamical compromise. And anticoagulation has to be individualized because bleeding risk is often high in the ICU. And we know that we have to balance between the bleeding risk and the stroke risk. But in ICU patients, the risk of bleeding tends to overshoot the risk of stroke. So in the ICU, the priorities would be to maintain cardiac output, prevent hypotension, and avoid negative inotropy or the contraction. So the preferred ICU drugs includes amiodarone 1, which has minimal negative inotropy and which is safe in LV dysfunction and shock. Esmolol is the other drug in rate control, which is preferred because it is ultra short acting. But as I mentioned before, it should be used only if there is no hypotension. In patients with unstable AF, that is those who are with hypotension and shock, we should consider synchronized cardioversion, which is always biphasic now, and along with short-acting sedation, where some people prefer etomidate nowadays. Others can be used too. But the important point is that recurrence is common unless the triggers are corrected. In case of stable AF, we have to consider rate versus rhythm control. The strategy of rate control is the first line in the ICU, and the rationale is that AF often resolves with improvement in the illness or the condition for which the patient is admitted in the ICU. Rhythm control is the strategy should be adopted in selected cases, and the rationale being that new onset or severe instability would benefit by rhythm control. So when we consider anticoagulation in ICU atrial fibrillation, we have to think about any new onset AF in the ICU. First, we have to stabilize the patient, control the rate or the rhythm, correct the triggers, go for a daily rhythm assessment. If the atrial fibrillation is resolved within 48 to 72 hours, there is no requirement of therapeutic anticoagulation, and we can continue the standard VTE prophylaxis. If the AF persists or recurs, then we have to reassess the bleeding risk, consider heparin, that is unfractionated heparin, and plan long-term strategy post ICU. If the atrial fibrillation is less than 48 hours, there is no routine therapeutic anticoagulation is required, especially if patient is if there is hemodynamic instability or if there is high bleeding risk. And in those cases, use mechanical DVT prophylaxis with or without. We can use for low dose of pharmacological prophylaxis if only safe. If the duration of AF is more than 48 hours, or if the duration is unknown, we have to ask three questions. One is that, is this AF persistent despite illness improvement? Two, is the bleeding risk acceptable now? And three, is the cardioversion planned? If no to any, then we have to delay anticoagulation. If yes to all, then we have to consider anticoagulation. So what should be the choice of anticoagulant in such patients in ICU? The preferred choice is unfractionated heparin. Why? Because it has short T-half, it can be rapidly reversed, safe in renal failure, and it can be easily stopped for the procedures. Low molecular weight heparin should be considered only if there is stable renal function, low bleeding risk, but we have to remember that it is less controllable once it is given. Direct acting oral anticoagulants or DOACs, they are generally avoided in acute ICU phase because of their unreliable absorption, drug interactions, difficult reversal, and renal or hepatic dysfunction, which is very common. What about the CHAD score or the CHAD's VAS score, CHA2 DS2, that is the modified CHAD score in the ICU? This is often useful after the acute phase in the ICU, but you have to remember that it overestimates stroke risk during transient ICU atrial fibrillation, and it should not drive early ICU decisions alone. So a holistic approach should be undertaken by considering all the risk factors and the clinical hemodynamic stability along with the drugs the patient is getting. So ICU atrial fibrillation anticoagulation is individualized, dynamic, and a conservative process. Now, coming to the ventricular arrhythmias, if the patient is having unstable VT, we have to go for immediate synchronized cardioversion. For stable VT, the first line is amiodarone, but lidocaine can be given if it is ischemic VT or amiodarone failure is there. For VF or pulseless VT, cardiac arrest management, and this should follow immediate defibrillation, high quality CPR, and the ALS protocols. Torsidis dipointis or polymorphic VT with prolonged QT, we have to go for immediate management and give magnesium sulfate 2 gram IV bolus, stop all QT prolonged drugs and correct potassium to high normal or higher side. If it is recurrent, this torsidis dipointis, then increase the heart rate by isoproterenol infusion and also consider temporary pacing. But avoid amiodarone in true torsidis because it can prolong the QT. There can be bradyarrhythmias and AV block. If the unstable bradyarrhythmias, the atropine is often ineffective in the ICU, so we can avoid, and we have to consider early transcutaneous pacing. If there is persistent or high-grade AV block, then temporary transvenous pacing, especially in inferior wall MI, drug-induced block, and electrolyte abnormalities. In case it is a device-based ICU intervention like temporary pacing, we have to consider bridge to recovery or permanent pacing. The indications being again complete heart block and symptomatic bradycardia refractory to atropine. While in electrical cardioversion, it is always synchronized for organized rhythms and defibrillation is reserved for VF or pulseless VT. So what are the drugs which are commonly problematic in the ICU arrhythmias? Because polypharmacy, as we can realize, is a very big cause of ICU arrhythmias. And unless someone is aware of the drugs, he may not able to correct the situation. So catecholamines and vasopressors like norepinephrine, epinephrine, dopamine, dobutamine, they can all cause arrhythmias. They can cause AF, they can cause SVT, they can cause VT. Antiarrhythmics like amiodarone and the class 1 agents like flecainide, procainamide, although they are antiarrhythmics, that they also can paradoxically be the risk for ICU arrhythmias, new onset. It is QT prolonging antibiotics. Like common offenders are the fluoroquinolones, levofloxacin, moxifloxacin, macrolides like the azithromycin, clarithromycin, and the arrhythmias causes QT prolongation and torsidis dipointis. Antipsychotics and sedatives like haloperidol quetiapine, ziprasidone, etc. are also responsible. Digoxin can cause arrhythmias. It can cause atrial tachycardia with block, junctional rhythms, ventricular ectopic, and complete heart block. Beta agonists, which are extensively used in ICU, they can cause arrhythmias like SVT, AF, or ventricular ectopy. The diuretics used can cause arrhythmias like AF, VT, and indirect torsidis. Sedation and analgesic, if there is under sedation, there will be catecholamine surge, which can lead to AF or VT. Over sedation can lead to bradycardia, heart block. Dexmedetomidine has a propensity to cause bradycardia and sinus pauses. Propofol has a tendency to cause bradycardia, although heart block due to protocol is rare. So, what should be the practical ICU drug safety strategy? We have to identify the high risk combinations. Like macrolides along with antipsychotics is one high risk combination. Amiodarone along with fluoroquinolone is a high risk combination. Diuretics with beta agonist is a high risk combination. Digoxin with amiodarone is a high risk combination. So we have to identify high risk combinations of arrhythmias and try as much as possible to avoid them. We have to go for a daily ICU checklist, review the QT drugs, the QT segment, review the electrolyte trends, and review every morning during the rounds the complete drug list. What we should do, we should proactively replace potassium and magnesium, and even if it is near normal or close to normal or just little less than normal in magnesium, any correction will always help to avoid or prevent arrhythmias. Then review the QTC daily in high risk patient. De-escalate vasopressors early, as we know that they can cause arrhythmias independently, and minimize polypharmacy as much as possible. What we should not don't stack QT prolonging drugs, should not ignore bradycardia arrhythmias on sedation, just saying that on sedation bradyarrhythmias are the rule, and assume always arrhythmia to be a primary cardiac disease, because in the ICU they are almost always secondary. So in the ICU, the drugs are often the trigger, amplifier, or perpetuator of arrhythmias. So what is the prognosis? Any new onset arrhythmia increases ICU mortality. Persistent or recurrent arrhythmias are worse outcomes than transient episodes. Ventricular arrhythmias have highest short-term mortality. Torsidis pointis is highly preventable. When it occurs, it often reflects a system failure. That may be because of polypharmacy failure, electrolyte neglect, whatever it is. Ventricular arrhythmias often indicate imminent physiological collapse. Persistent AV block requiring pacing indicates worse short-term prognosis. But most importantly, one should remember that trend matters more than a single ECG. So, what should be the final take home message? Arrhythmias in the ICU are usually secondary, not primary. Hemodynamic stability decides everything. New onset AF in ICU is a severity marker. Electrolytes are active antiarrhythmic therapies. Amiodarone in the ICU is the ICU workhorse, but it is not for everything. We should know that when we should not use and what are the side effects. Anticoagulation in ICU atrial fibrillation must be conservative and individualized. Drugs are common and preventable uh, arrhythmia triggers, so we should be careful with the drugs. Ventricular arrhythmias are ominous prognostic signs. Persistence and recurrence matter more than the first occurrence, and arrhythmia resolution mirrors recovery, because as patient recovers slowly, the arrhythmias also settle down. So they go hand in hand. But not of course, the most important is that the diagnosis and management of ICU arrhythmias is always a teamwork. So one need to undertake it in a very systematic manner. If one is not able to diagnose but still feels that there is a strong possibility of arrhythmia, they should take help from allied branches or some in the same profession, other friends and colleagues, so that it should not be missed. Thank you very much.